In the interest of time, um, let's get started with the usual introductory spiel, so we can clear that on the way to the really interesting stuff that Marilyn is going to talk to us about today. So as you may already know, my name is Einat Danieli. I'm the clinical manager for the Behavior Support for Seniors program at the Toronto Central LHIN, based at Baycrest Health Sciences. I want to welcome you to our BSO COVID and Responsive Behaviors Lessons Learned from the First Wave education series. This is our fourth and concluding session of that series. So we're very excited. Very excited. Response has been wonderful to date, and people have been very well engaged. The series is a collaboration of the Behavioral Support for Seniors program at the Toronto Central LHIN, the Center for Learning, Research and Innovation at Baycrest, the Psychogeriatric Resource Consultant Program of Toronto at RGP Toronto, and Alzheimer's Society of Toronto. A few housekeeping stuff before we get started. I want to remind you to mute yourselves unless speaking. When you wish to speak, you're welcome to unmute yourself to ask a question. You could also, next to your name on the participant list, you'll see a little hand where you could click on that to raise your hand so that we know you want to ask a question, or you could simply just write it in the chat. We will also leave about 10 to 15 minutes at the end of the hour for some questions and comments by participants. I want you to know that we will be recording this session. So this session is being recorded. It is also live streamed in a private link to YouTube for those that cannot access Zoom. And we will be sharing those recordings after the session. We'll be posting them on both the BSO website and the Center for Learning, Research and Innovation website. And our moderators will put those links shortly on the chat so that you know where to find the links to this session, but also to previous sessions if you have missed any of the sessions from this series. So as I mentioned, we're live streaming this also to YouTube to enable more participation. And so for those of you that are joining us through YouTube, if you want to ask a question, you need to be linked to your to a Google account to enable that feature on YouTube. And then you can just type your question on the chat and our moderator will copy it into our chat in Zoom so that we can respond to you. Take under consideration that there is about 30-second lag between us and when you're seeing us on YouTube. At the end of the session, we will also be posting, you'll see some poll questions pop up on your screen 2 minutes before the end of the session. This is for us to collect your feedback. We ask that you take a few seconds to fill that feedback so that we can continue and improve our lessons and education sessions to make them more engaging for you. So our topic for today, I'm very excited to introduce you to our topic, which is about supporting smoking cessation in long-term care in the era of COVID-19, clinical complexities and simple solutions. And this really speaks to the work that Marilyn White-Campbell, who is a clinical geriatric addiction specialist with the Baycrest long-term care behavioral support outreach team, has done with long-term care homes across Toronto Central LHIN. And we know that she's also supported many beyond that turf and has done that work over the COVID pandemic. And so she's going to speak to this work today. She is also the provincial lead and co-chair for the Behavioral Support Ontario Brain Exchange Older Adult Substance Use Collaborative. Marilyn is a co-investigator with CCSMH project to establish 4 national clinical best practice guidelines for substance use disorders in older adults, and is co-chair for the Alcohol Working Group. These guidelines were launched in January 2020, and she will also provide links within her presentation to those guidelines in case you're interested to read more about them. She's the recipient of the Ontario Psychogeriatric Award of Excellence and the recipient of the 2019 Mental Health Outstanding Care and Integrative Practice Award from the Canadian Academy of Geriatric Psychiatry and Canadian Coalition for Seniors Mental Health. Marilyn is trained through CAMH and UFT Faculty of Medicine's Training Enhancement in Applied Counseling and Health Program in Tobacco Cessation, called also TEACH. She recently launched a fact sheet, Older Adults and Cannabis, Know the Facts, with over 30, and she has over 34 years of clinical experience working with older adults with substance use disorders. She's recognized as a pioneer in the field of geriatric addictions and have helped some of our homes, I would say, declare themselves smoke-free forever over the pandemic. So without further ado, Marilyn, the stage is yours to share with us this wealth of knowledge and experience, and I would say also success over this pandemic period.
Okay, thank you. Welcome, everyone. Thank you for inviting me to talk to you today about smoking cessation. I don't have a slide for this, but I do not have any conflict of interests. We did receive some free nicotine spray from CAMH during the first wave of the outbreak. So, but I don't have any interest or ownership in any stocks of any type around nicotine replacement therapy. So just want to be very clear about that. We're going to be talking about some nicotine dependence and smoking cessation options, and look at a decision-making matrix for smoking cessation for residents of long-term care and for the community, and look at some of the approaches that we've used to enforce smoking cessation during outbreaks in long-term care homes, and look at some of the options for supporting an older adult who's engaging some risky smoking behaviors. So I wanted to ask this question of those of you in the audience. What are some of the problems that you see in your homes around smoking during this COVID-19 pandemic? And Matthew, you've got a poll question up there that everyone can click on that and give us your responses. Oh, that's the wrong poll. What are some of the problems that you see in your homes? So maybe we could ask you to put that in the chat box. Okay, so here's the poll. So no access to nicotine replacement therapy, residents leaving the homes to get cigarettes, sharing of cigarettes, residents smoking inside the home, sort of subversive smoking, or residents are upset that they can't go outside to smoke, and so subsequent behaviors. So if you could select what you're seeing in your communities and your work. Just give you a few moments.
And some people are saying on the chat, all of them.
Okay. So if we can see the results, Matthew.
And people are saying, Marilyn, that certainly a lot of them are experiencing more of those, more than one of these problems, but the poll only allows one choice, but that's what people are saying, that they're seeing more of those problems.
Yeah, so the largest number of your the residents that are upset that can't go out to smoke. Yeah, that's a really, really big one. Sharing of cigarettes, that's 15%. That's pretty high compared to no access to NRT. And people smoking inside the home, again, that's a really, really risky behavior. So hoping that as we move along in the presentation, you'll have some solutions around that. So one of the things is I want you to take into consideration that when you have residents that have cognitive impairment, that you're asking them to make some changes around their substance use, whatever their substance is. In this instance, we're asking them to make some changes around smoking, but they can't remember why or in fact that they're supposed to be making those changes. So take that into consideration. And that's why I think in the poll, we're seeing, most people are concerned about residents' behaviors, that they don't know and don't remember why they're not allowed to go outside. So this one is, what's the leading cause of substance attributable healthcare costs in Canada? So Matthew, if we can have the poll, so alcohol, opiates, tobacco, or cannabis. Okay, if we can see the poll. And if there's any comments in the chat box. So tobacco and alcohol, tobacco at 42, alcohol at 42 and tobacco at 49%. So yes, the reality is that in terms of substance attributable healthcare costs in Canada, this is in 2014, it's still true from the CIHI data from 2017, but tobacco is the most expensive, particularly in older adults, because at the end of life, that's when those health issues, the cancers and so on show up. But in Canada overall, cigarette smoking linked 37,000 deaths a year, and about 5 million people continue to smoke. So nicotine has a very, very high addictive potential. And we know that it's considered one of the most addictive substances because the nicotine from cigarettes is absorbed through the lungs when the person inhales. It reaches the blood concentration within a few seconds, and then it declines very rapidly. And that pattern is repeated and reinforced with every inhalation, that hand-to-mouth motion. And it's reinforced because the quick delivery of nicotine to the brain results in a faster and more intense response that leads to the addiction. So this picture shows the areas of the brain that are involved in addiction. So in terms of the nicotine's addictive potential, we know that smoking is very common in long-term care homes, with between 5 all the way up to 30% of residents who are smokers. So some of you have just smokers in your homes, and there are a lot. I know at one point there was a home that had, 3/4 of their population were smokers. So there is a misconception that smoking is just a habit, something that you can easily break, but it's not. If we think this way, it prevents us providing support to residents in long-term care. If we think about it as a habit, it impedes our understanding of, we're impeded by our understanding of smoking. It's not as easy as just stopping smoking. All of the substances that we have, of all of those substances, nicotine and tobacco are the most addictive. With very minimal exposure, such as 3 days of exposure to inhaled tobacco, you can become addicted. If we mention freebasing, if you think about freebasing, you wouldn't think about smoking, but other drugs like cocaine or hashish, etc. In fact, freebasing was invented by the tobacco industry. It made it very precise, and the filter at the end of the cigarette is a very precise and rapid way of delivering nicotine. In the 60s and 70s, the tobacco industry created that filter, and it contained asbestos, and now it contains ammonium and formaldehyde. And it's very sophisticated. It's a very sophisticated drug delivery device. That rapid delivery helps to induce and maintain the addiction. So we have to recognize that addiction is a neurobiological disease of the brain. So you see here on this chart that the probability of dependence after trying a substance at least once, so at the very top of this list, next to heroin and cocaine, you have a 32% chance of becoming addicted with tobacco. So it's like injecting a drug. It's very highly potent. 1 milligram of nicotine does the trick, and that means 1 cigarette does the trick. It's got a short half-life of about 120 minutes, although some of your residents that are smokers in long-term care homes, they smoke every hour. Its addictive effects are similar to cocaine, heroin, and amphetamines. Again, it's that repeated inhalation absorbed through the lungs. It's very, very quick. So it's not just the nicotine that we're worried about. This is a picture of a cigarette, and it's all of the chemicals that are in the cigarette. So you see there's lighter fluid, toluene, nicotine, insecticide, ammonia, carbon monoxide, methanol, methane, arsenic, lots and lots of chemicals. There are over 2,000 chemicals in a cigarette, and about 800 of them are known to cause cancer. So we're not so about the nicotine as we are the other chemicals, and it's the burned tobacco that we want to discourage in smoking. So the nicotine is not the harmful component. It is mostly the chemicals when a cigarette is burned. But we know that quitting is a process, and as you see here, Mark Twain says, giving up smoking is the easiest thing in the world. I know because I've done it thousands of times. So people try, and you'll ask people, have you ever tried to give up smoking? And they'll say, yeah, sure, I did, for 4 weeks. Well, tell me about that time. Yeah, I was in the hospital. I couldn't smoke. What do they do in hospital? They put a patch on you, or they give you a nicotine inhaler or the spray. So if you think about it, a pack-a-day smoker has approximately 110,000 hand-to-mouth repetitions a year. So if they've been smoking for 40 years, started at age 13, now at age 53, they smoke a pack and a bit a day over 40 years. That's 365,000 cigarettes and 4,380,000 hand-to-mouth repetitions. So think about, we're asking people with frailties, people who have been smoking for 40, sometimes 50 years to stop smoking. So can I ask you quickly to respond to this poll question? Do you use nicotine replacement therapy in your home? Just a yes or no. Okay, if we can see the results. So we see that about 64%. I'm hoping that we've got lots of people for the TC Lin in here, but 36% are not using it. So I'm hoping that you'll learn something today about use of nicotine replacement that can be helpful to your residents. So the older smoker are often very heavy smokers. They're more likely to have chronic diseases and higher levels of nicotine dependence. And that cognitive impairment, along with smoking, can make the quit challenging. And also people with mental health issues that have been smoking for many years, it can be very challenging. They have, at this stage of life, they do have a reduced nicotine metabolism. They're less likely to be counseled to quit. Family members will say, oh, it's their last remaining pleasure. Why stop them now? But some studies do show that that older adults have higher success rates for cessation even than younger smokers. And people have different motivations for quitting. So some people quit because of health reasons. Some people quit because they want to be able to have a visit with the grandchildren. Some people quit because they want to make changes in their budget. When the price of cigarettes go up to, they will say, oh, when cigarettes reach over $10, I'm not going to smoke anymore. But oh, $11, it's okay. So we know that older adults have different reasons. But smoking is associated with all three major causes of death among elderly. So heart disease, cancer, and stroke. So the risk of dying from a heart attack is 60% higher for smokers than non-smokers, 65 years or older. And we know that people who smoke are more than 2 times as likely as non-smokers to develop Alzheimer's disease and dementia of any kind. So myth or fact, should nicotine replacement be used in persons with cardiac conditions? Yes or no? Is it true or false? If we can ask Matthew to put the poll up. Okay, I'm just going to look quickly in the chat box. Okay, we don't see that question. But in any case, should it be used with persons with cardiac conditions? And the truth is that it is even more safe than, much more safe than smoking itself. Again, remember the picture of the cigarette. When you light that cigarette up, there's all those toxins, all those chemicals that are burning. So it's the burning, actual burning of those chemicals and the inhalation into the lungs that cause the disease. So the smoke itself causes increased heart rate, increased blood pressure, and increased clotting time. There has been some research to show that nicotine replacement has not been associated with any increase in cardiac events. For instance, heart attack and stroke. One of the things that many years ago, we did have nicotine replacement available to every resident in long-term care homes, but there was a reluctance to use nicotine replacement therapy because the thought was if the resident went out and they smoked, that they would end up having a stroke. Well, it's not. It's not true. People, if they do go out and smoke, they'll feel a little lightheaded, and usually they don't even finish the cigarette. So they would extinguish the cigarette and then go back inside. So one of the things that we want to do when we're treating people with nicotine dependence is to screen. So this is a test that we used with some of the residents in long-term care. The Fraggerstorm test for nicotine dependence. You can get that on the internet anywhere, or I can send you the copies of it. So they're asking how soon after you wake do you smoke your first cigarette? Do you find it difficult to refrain from smoking in places where it's forbidden? And in this instance, we know that lots of residents that are really highly nicotine dependent, if they can't smoke outside, they can't smoke inside, then they'll do it subversively. And usually the place that they do that is in the bathroom. And sometimes if there's cognitive issues, they may elect to have the cigarette and extinguish it in the waste bin where the paper towels are, not in the toilet, but in the waste bin. So there is a risk for fires. So we want to make sure that we support people to make sure that they're not smoking in the washroom. You're asking which cigarette of the day would you hate to give up? How many cigarettes in a day do you smoke? Do you smoke more frequently in the morning? And do you smoke even if you're sick in bed most of the time? So there's a scoring tool here. You want to add up the scores from the questions. But the one question that I find is the most helpful is, how soon after you wake up do you have your first cigarette? And that speaks to the level of nicotine dependence, because if somebody is, gets out of bed and even if they're wheelchair bound and they get in their wheelchair and they go outside for a cigarette before they have their breakfast, before they have their, their medications, etc. Or if somebody gets up out of bed and they go with a cigarette in their mouth into the washroom before they have their first, pee in the morning, that they're very, very dependent. So that's a real indicator that they're very dependent. If you can't get these answers out of the person, you might say to them, what's the craziest thing you've done for a cigarette? And that might be, I borrow from cigarettes from people if I'm out, I stole cigarettes from Joe, took some out of his pack when he wasn't looking. So what's the craziest thing that you've done for a cigarette? So what we want to do is establish the risk for smoking. Are they able to go out safely on their own or not? Are they smoking safely and alone? During COVID, this is the one thing that really sort of tweaked my concern when I asked, are they picking up cigarettes or use cigarette butts? Because in COVID, someone with dementia is going in and they're a smoker and they see a half smoked cigarette on the ground, they may pick it up and smoke it or even eat it. So the risk for transmission is really very high in this instance. So what you want to do as soon as if this becomes a concern or if you're aware of it, then I would escalate and initiate some nicotine replacement therapy right away. The other thing to consider is, are there some behaviors that cause arguments or fights over cigarettes? And again, that's another reason you want to escalate and initiate some nicotine replacement. Now, if someone is unable to go out, or they're in isolation, they're COVID positive, then is there a risk that they're sharing cigarettes with other people? Are they using smoked cannabis? Again, these are all reasons you would want to escalate it and make it a bit more urgent that you initiate some nicotine replacement. Looking at unsafe smokers, have they got burn marks on their clothing, in their wheelchair or their scooter? So is that just a yes or no? If there is, then you need to enforce the use of the smoking apron and encourage nicotine replacement therapy. So what if they're not able to go out? What if they're COVID positive? They've got a cough or a cold present. You need to offer nicotine replacement therapy, whether or not the person is planning to quit. Or if they've got the following, so if they are active COVID or their isolation due to other illnesses, or some people have gone out to hospital and they come back and they have to isolate. So these are some of the reasons where you would want to initiate it right away. So look at the physical environment. So what's the smoking area like in your home or in your community centers where there are seniors? So you need to ensure social distancing. You want to tape off the areas to indicate a 3-meter distance. And I had suggested to the long-term care homes to keep a bottle of quick mist nicotine spray in each of the nursing stations to use it as needed if a resident is agitated and not consolable, or they're not able to go out for a cigarette. So the one thing for sure is once the canister is open, you don't share it with other residents, and there's some instructions with that. Again, screening for a nicotine dependence. There's other tools besides the Fraggerstorm. There is a CAMH algorithm. And when you think about it, usually in addiction treatment or in most treatment programs, even in the nicotine dependence clinic, you have to show some motivation. To attend the groups. You have to show up, you have to, take a 3-hour, attend a 3-hour group, do some screening tests, do an oxygen test, etc. So there's lots of steps to go through that show and demonstrate your motivation to change. But I'm thinking in this, in the situation where with COVID and residents in long-term care, motivational interviewing really might not yield a positive response. During the quarantine, abstinence for smoking will be mandatory. People can't go out. They're sick, they're in bed. You still want to be kind and compassionate. You want to let the resident know that they don't really have a choice right now for this period of time, and remind them it's not a permanent situation. So again, some care and compassion is involved here. And it's not just saying, well, I'm sorry you can't go out, but we've got some solutions here to make sure that you're comfortable. So the area, we want to make sure that the area is fenced in, or an approved ventilation room, taping off 3 meters on the ground in colored tape, using closed ashtrays, making sure that that people can't dip their hands into the ashtray to pull out cigarette butts. And if that's not possible, making sure there's somebody to continuously monitor the smoking area and sweep up the butts from the ground, and do it in a safe way, of course. Check and see if they're extinguishing half cigarettes and storing them in their pockets. You want to do that to reduce the risk of fires. Asking residents not to share cigarettes and lighters because it's possible, and it's possible, make sure the grounds are cleaned regularly. Ask the person to clean their hands and lighters. If you think about it, a resident who has COVID that's asymptomatic may be going out up to 15 times a day, pressing the elevator button, going down to the front door, pressing the pass key to get out, having a cigarette, maybe putting that cigarette butt on the ground, and then coming back in. So just think of all the times they've touched the surfaces and they've had the cigarette close to their mouth. So we did, in some of the homes, we posted signs to remind residents of the risks of COVID-19. So asking them to make sure that their hands are clean before you smoke, keep 6 feet between you and the next person. We asked them to reminded them of the high risk of disease transmission. So don't share cigarettes or other smoke or vape products. So that included cannabis or using e-cigarettes. and asking residents to extinguish their cigarettes and put the butts in the ashtray. Also not sharing lighters, because again, you know, the person has been touching the cigarette and near their mouth, inhaling and exhaling. So you want to clean them before and after using, making sure that those are not toxic. The cleaning products are soap-based, not alcohol-based, because that's flammable, the hand sanitizer. So most of the folks that are heavy smokers will need combination therapy. So counseling and smoking cessation medication is more effective than either treatment alone. So therefore, you really need to look at providing both. So what we did in the TC Lynn was we used OTN e-visits with the primary care to receive the report during this time. And I would see the resident on OTN, and we would develop a treatment plan. We didn't tell people you have to stop smoking. And when you think about it, if someone goes to the hospital and they've had a heart attack or they've broken a hip, and they're a heavy smoker, the doctors, you know, generally say, well, we'll treat the smoking cessation while you're in the hospital. There's a model of Care for the Heart Institute in Ottawa, and also in Edmonton, and everyone that's offered, everyone that comes to the hospital who's a smoker is offered and given nicotine replacement and their choice of nicotine replacement. So the nicotine spray is put on the person's night table for them to administer, or they get a patch. So combination therapy may be needed for extremely heavy smokers. If somebody smokes over 1 pack of cigarettes per day, they may need the patch and some other form of short-acting nicotine replacement, which might be the nicotine lozenges, inhaler, gum, or the spray, and the counseling. And some people actually may need more than 1 patch. So it's very individualized. You want to make sure that the person is successful when they use nicotine replacement, find out what's worked in the past and what methods they would like to use during this time of quarantine. And people said to me, well, I've used the patch in the past, but it didn't work. And it turns out that that person may have gotten a 21 milligram patch, but they actually, you know, instead of a 21 milligram patch would be for somebody who smokes 1 pack of cigarettes a day. But if you smoke 25, 30, 35 cigarettes a day, a patch is not going to touch that, that strong craving that you have. So some people can use more than 1 patch. Some people can use, you know, who smoke 2 and 3 packs of cigarettes can use, you know, 2 patches and then use something for breakthrough cravings, the short acting. What we did is we asked people, what would you like to use during this time of quarantine? Remembering that these are difficult times. We want to keep you safe. We want to keep our resident population safe. And so we're offering some support. What methods would you like to use? And so what we did was we showed them the different types of nicotine replacement, and they were able to choose what they wanted. So there was some ability to make some choices, and residents felt good about those choices. So again, nicotine patch is given according to the amount that the person smokes, and you use combination treatment for breakthrough cravings. So it's individualized. Look and ask what they want to use during this time. So here's the dosing. There's for a light smoker, somebody who smokes less than 10 cigarettes per day, you would use the 14 milligram patch. And somebody who smokes 10 to 29 cigarettes is a moderate smoker, so they would use 21 milligram patch. We're not looking at a time frame during this, because with COVID, some people were needing to use it for quite a bit longer. And if somebody who smokes 30 cigarettes per day, you can use 28 milligrams. So you can have a 21 milligram patch and a 7 milligram patch. Plus you can use the short acting gum lozenge or mouth spray or inhaler for breakthrough cravings. So this is the Quick Mist, and it contains up to 150 sprays. I like the Quick Mist because it because it's very quick. I'll give you an example. We had one resident in long-term care that was having some behaviors around smoking, and he would go to the nursing station and actually struck a staff because he didn't get his cigarettes right away. They would hand over a couple of cigarettes. So what we did was we said, well, George, sit down, have a cigarette. I'm going to get your cigarettes, but I'm going to give you some medicine first. And so the nurse would spray into the side of the cheek. And then she'd say, just hang on a second, George, I'm going to get them now. And by the time she would turn her back, within 30 seconds to 2 minutes, the spray takes effect, and off George would go, forgetting that he asked for a cigarette. So the nicotine spray works very, very quickly, again, within 30 seconds to 2 minutes. Certainly this is pretty obvious, but if you have residents who are self-regulating and using the spray on their own, remind them not to share with others. If the person is still agitated, if you use the nicotine spray and they're still agitated, then look for another cause because it may not have been a cigarette craving. So look at other causes for agitation. The usual dosing is 1 or 2 sprays to replace 1 cigarette. So if you want to trial it, you can put it on a gloved hand, pump that canister, and so it doesn't produce a mist, put a droplet, and then rub it on the gum or the cheek. And if they get relief from that, it's most likely a good choice for nicotine replacement for that person. So the nicotine spray is kind of difficult to use. You have to push the black button down, and it's kid proof. So I had a lot of trouble getting to open it. So again, you have to push it in and then slide it upwards until it locks into place. So again, you need to prime it the first couple of times so that you get the mist out, and then close it up when the person's finished with it, because you don't want other residents getting into it. So when you're feeling the urge to smoke, you use it, and you'll need to spray less and less over time in order to control your nicotine cravings or withdrawal symptoms. And that's the whole crux of this, is to make sure that the resident or the person in the community is comfortable. So we don't want people being in nicotine withdrawal and then not being able to do anything about it. So again, this is a comfort measure, especially during COVID. So if the craving doesn't disappear, then you can administer a second spray, but no more. That's a good dose of nicotine. So sometimes people get a little bit of tingling on their lips. Sometimes if they spray too much, then they might get cankers on the side of their mouth. But again, that tells you that they're maybe using it too much. We ask people to not inhale it and don't spray it into the throat. So here's the dosing for it. Again, this has a titration and for a person who's planning to quit. We're using it during COVID to make sure that people are comfortable. There's no harm from using the nicotine. People are addicted to cigarettes. We're mimicking or mirroring the amount of nicotine that they use on a regular basis from smoking. So the maximum doses are 2 sprays at a time, maximum of 4 sprays per hour or 64 sprays per day. We had some residents that were very interested in self-regulating, and we found that they weren't able to self-regulate. And what happened is the person actually ended up becoming quite nauseous. We had to bring the spray back to the nursing station and administer in a way that mimicked their smoking. So lozenges, the nicotine lozenges are used for people who are able to remember, and that's the key piece. They had to remember to put the lozenge in the side of their cheek, to park it between the gum and the cheek, and sort of suck on it until they feel the nicotine working, and then let it go and let it sit there. And then they can repeat it. So it might take about 20 minutes for that lozenge to dissolve, but it's important that they not take that lozenge and chew it. The chewing the lozenge will result in excess nicotine and possible nausea. So, and some people don't have the ability to control that chewing. So it's not recommended for people who have poor impulse control. So the one nice thing about the nicotine lozenge, if you buy the no-name brand ones, they're a bigger tablet, and you can break them into pieces. And that, again, is a way to help people sort of cut down and titrate. So you can take a 2 milligram lozenge, cut it in half, and break it down even to a quarter lozenge. So again, it is a costly way to, it's no more expensive than it is to buy cigarettes. In fact, it's cheaper to buy than cigarettes, but it can help people to control their dose and the costs related with their nicotine replacement. You don't really, when you put the lozenge to the side of the cheek, it's not ideal. Like sucking on it produces a lot of saliva. So you want to make sure that it's in the side and it goes into the saliva glands. Again, if it's not well tolerated, if it's too much, break the lozenges into quarters and make sure the person has access to those lozenges as they need it. Again, the whole idea is to prevent them from, going outside when they're, sick or infected with COVID and possibly transmitting to other people. So making sure that they're comfortable and they have the amount of nicotine that they need. So the nicotine inhaler, this is a picture of the inhaler. It looks like a little plastic cigarette tip. It's a great solution for people who are heavy smokers and they like that hand to mouth action. So what we do is you load them up with these little ampules inside here, and there's foil at each of the ends, and you load it up into the plastic mouthpiece. And that little plastic ampule has the nicotine in it. So does have some drawbacks. If somebody has dexterity problems, you need to load it for them. And once it's punctured, it's good for 48 hours if it's left unused. Or if somebody sits there and they toke on it for 20 minutes, then they've used up all the nicotine in it. It should be used over the course of, the hours, for a heavy smoker, somebody who smokes a cigarette an hour, you should be able to break it down into 5 minutes sort of smoke breaks. So 5 minutes, 4 times in 4 hours. That will give them enough and they'll get the sensation of having smoked. The one thing is the nicotine inhaler is a more expensive option compared to the patch and the lozenges. If they're able to open the plastic mouthpiece, they may be, and they can put it together and they can know and understand when it's ready, when it's drained, then they may be a good candidate. Remember, there's only one of those plastic mouthpieces. And if they lose it, then have to buy another one. So I suggest always in long-term care, just get a piece of Scotch tape, not anything stronger than that, but just a piece of Scotch tape with a string around it so that it hangs around their neck and they don't lose it. If they were smoking independently outside in the smoking area, it may be a good alternative, again, because of the hand-to-mouth motion. So a nicotine gum is least favored for older adults because of dental care. They may have dentures, crowns, and missing teeth. But if they like to chew gum, it's a great option. You give one piece, and again, they have to remember to be able to chew it, and then park the gum in their cheek. If they take it and chew it like a piece of gum, they'll get an upset stomach because there's too much nicotine released at once. There is a concern around having gum that some residents may share it with other people. So you really need to screen and ensure that it's a safe method for them. Sugar. This one is the big surprise. For low-level smokers, people who smoked only a few cigarettes a day, we used sugar. We used candy, mints, lollipops. It keeps the hands busy if they have a lollipop. You don't use it if the person is a brittle diabetic or overweight, morbidly obese. But for somebody who has Alzheimer's and they're underweight anyway, this isn't going to harm them. The sugar will help to, again, this in the same way as nicotine replacement, it'll help to deal with those cravings. So the whole idea behind smoking cessation is to ensure they're not in withdrawal from nicotine, and their serum nicotine levels are kept at similar levels when they were smoking. So for somebody who's smoking 15 cigarettes a day, you want to have nicotine replacement to achieve those levels. The same with somebody who smokes 35 cigarettes. So and with cognitively impaired, if they're asking for a cigarette, let them know you're going to help them out. Use the nicotine spray in the mouth. Get them to wait. So if you're delivering nicotine spray, make sure they're sitting down because it can cause people to be dizzy. Ask them how they feel. And remember that it takes 30 seconds to 2 minutes to enter the bloodstream. So it's the quickest way. There are some side effects though. There's tingling to the mouth and the lips and sometimes hiccups. And the hiccups will be very evident if they've taken too much. So in terms of capacity, there's ethical considerations with those who smoke and may not understand and appreciate those risks of COVID-19. I'm just going to quickly look and ask you to start posting your questions in the chat. I'm almost finished my slides here. This is Mr. C. This is somebody who is 74 years old, a history of schizophrenia, antisocial personality disorder. He's mobile, he's COVID positive. He's not very pleasant when it comes to his smoking. He smokes between 20 to 30 cigarettes per day. He demands the cigarettes and they give him 5 cigarettes at a time. He's combative. And then he'll go away those 5 cigarettes and come back and tell the other nurse, well, I didn't get my cigarettes yet. He was refusing to stay in his room. He was non-compliant with his use of his mask. He had poor hand hygiene, was leaving the floor up to 15 times a day. Again, remembering touching all of those buttons and not using his mask, etc. So what would you do? You know, call the police and charge him under the Quarantine Act, take away his cigarettes, and tell him to stay in his room and provide NRT. So that's what we did. But I want to say, first off, I mean, the provincial orders, there is no Quarantine Act. And the Quarantine Act only applies to people who are out of the country that are coming into Canada. So in the province right now, in the Toronto area, we are under the Health Protection Act. So there's 2 parts of that. The PPE is mandatory. It's been ordered by the Chief Public Health Office and the local medical health office. So under the Health Protection Act, an individual or an entity, you're allowed to, it allows for isolation or detention of a person who is exposed to an infectious disease. So COVID-19, HIV, someone who's knowingly infecting people, or someone who has tuberculosis. So there are some provincial orders in place, but for people who are living in long-term care, there's no need to really use the Health Act when you have some ability to provide some nicotine replacement for people's comfort. So if you have somebody who's transitioned to long-term care, you want to look at adapting a gradual reduction using a patch, so 21 milligrams, and then using the spray as needed, the gum or the inhaler, and using short-acting. If you're using a person is using less than 9 cigarettes per day, you want to look at using short-acting nicotine replacement, or even the sugar worked very, very well. So I want to mention that the gentleman that the gentleman that was going in and out, once he had the right dose of nicotine spray, he did not like the patch because the patch gives you nightmares sometimes. And for him, it irritated his skin, so he would take it off. So he tried the nicotine spray, loved it, and he stopped going out completely. He was very happy with that. He stopped going to the nursing station, and his personality really changed, and the staff were really delighted to see the change in him and gave him lots of positive reinforcement. So e-cigarettes. Not all e-cigarettes have nicotine, so beware of that. Cognitively impaired have problems using the products, and they won't understand why they're giving it, and they could light the device. So it's not always a good choice. The good thing about an e-cigarette, though, it does mimic the action of smoking. It reduces the risk for fire, and you can reduce the nicotine content over time. There's some costs associated with it, and you can use different types of e-juice ranging from high to low, which reflects the person's nicotine use, and you'd really need to use from a shop that's reputable, not just buying it at the corner store, because you don't know whether or not the e-juice is tainted or if it's actually got nicotine in it. So now we've got a few minutes for questions. Let me look in the chat box here.
Thank you, Marilyn. There is one question that is about the cost so far, and if you have any additional questions, please post them on the chat. One question that came in is there any cost passed on to the resident for the different replacement therapies?
So what we did is we offered residents the range. And for the residents in long-term care in the Toronto Central LHIN, we had the option of using the nicotine spray. When people were offered a free option, they took it. So some homes were actually able to offer, able to offer the patch, but most homes only had the nicotine spray. But when people were offered the spray, they took it. And again, because it's very quick acting, it was very, very effective. The cost itself, the spray is $42.99 at the regular stores. I think you could buy it cheaper at Costco or Walmart. So, some of the big box stores have it, and you can buy them in packs of 2 and 3. So, the inhaler has a similar cost. The cheaper lozenges are around $32. The patch between $24 and $28. Again, you can buy them cheaper if you buy them in bulk or at the big box stores. And some, I found that some of the long-term care homes, if they ordered it from the pharmacy, you don't need a prescription for it, but you do need a doctor's order, because the nurses will be administering the patch or the sprays or whatever. So it needs to be on the MAR sheet. But some of the pharmacies actually charged a fee for dispensing the product. So family members can buy it and then give it to keep in the nursing cart. Do the e-cigarettes give off any fumes? There is. It's a vape. It does have some fumes, but it just doesn't have any flames associated. Some homes are leery of them. Yeah, it's a good option for somebody who really doesn't want to stop smoking completely. And if they're smoking inside, this is the lesser of two evils. It is not without harm, but it's less harmful than smoked tobacco. That's for sure. There's 480 toxic chemicals versus 890. Oh yeah, I see Margie and Gur, the champions of Casa Beachwood Towers. They paid for the nicotine patches, and they offered it to the residents under a compassion program. So again, in these times of COVID, if there's a way to support your residents, again, it's nice for them to have options. And as I said, we did have a donation of the nicotine spray from CAMH. And it worked out very well. Some of the homes, actually, there was one home in particular that actually became smoke-free. And it wasn't just, it was, everyone was offered nicotine replacement, but they also used sugar. And when residents were looking to go downstairs for a cigarette, someone who was actively COVID, they were looking for a cigarette. The staff knew once the person was at the elevator that they were looking for a cigarette, so they would be offered either the spray but also a beverage. So a cola or a sugar-based drink. They had root beer at the nursing station, so they give a little Dixie cup of root beer. Some places used those little chocolates that are little individual pieces of chocolate, and again, the sugar worked famously. So Any other
Marilyn,
questions in the chat box?
oh, there is one that just hopped in. Heavy smoker, suspected case, part of floor is an outbreak that needs to travel by elevator to the lobby, then to the garden to smoke, refuses patch, can self-propel cognitively and cognitively intact. How best to manage aside from, so basically they want some tips on how to enable that in a safe way.
Yeah. Well, I have to say that one of the things that they did really, really well at Castleview, Woodwood Towers, and also Fudger House, is that everybody was offered something and they were given a trial of it. So it wasn't that they, here's a patch and don't smoke anymore and don't go out. What we did was we, the behavioral support nurse would bring the nicotine spray or the products to the OTN session, and they also got a demo and we showed them, and then they chose. Again, it's about agency, people having some agency around their choices, and so we had 15 residents, and no one said, I don't want anything. There were 10 residents, so there were 25 residents in total. 10 of them were low-level smokers, and they chose to just stop cold turkey. They were smoking 2, 3, 4 cigarettes a day anyway, so it wasn't so much of a concern. But the heavier smokers, when offered something, they all tried it and they took it. And again, because the nicotine spray was really quick, and they got the hit. And again, talking through what it feels like to them. Do you feel like you've had a cigarette? And if they didn't feel anything, then they needed maybe a second. Again, for a heavier smoker, they maybe needed a second spray. So once you have the person, once you have the nicotine, serum nicotine levels at a steady. They're at a steady level and they have something for breakthrough cravings, there's no need to go in and out. We had one resident who actually was quite pleased with using the patch because he didn't have to go out. I mean, it's getting cold now, but it was even in the nice summer months. It meant that he had to go outside sometimes. Had cigarettes, and sometimes he didn't. He would have to borrow for people. He'd have to stem. He'd have to pick up cigarette butts. So he realized that he didn't have to worry about that anymore. So he was quite comfortable, glad to stay in his room. He was much more relaxed. And he was somebody who had mental health issues, and so again, having your nicotine levels going up and down like this all the time, and then all of a sudden not being able to have anything, it really made a big difference. So again, the gentleman who had COVID, who was going out against medical advice, once he had the right amount of nicotine, he was just very, very calm. So
I guess to your question, Faida, then you've learned about a lot of other options beyond the patch. So maybe if the patch is not the right one, maybe try and offer some of those other options explored or introduced today. Time, I want to take this opportunity to thank Marilyn for this great presentation that is really based at a lot of work that has been put and provided through the pandemic, and the work that you did with the homes, and also some education on this across the province. I really thank you for being with us today and providing all those very practical tips and ideas, which I hope our audience will find effective and will be able to implement in their home. Our poll questions are going to pop up on the screen any second now. Please respond to those. Let us know how we did. And I want to thank everybody for participating and joining us today.
And thanks, everyone. And feel free to reach out. The resources are on the slides as well, so you can click on those links, and the tip sheet that I created is on the BSO Brain Exchange website.
Great. So lots of warm responses are coming out on the chat. We will, of course, share the recording and the slide deck from this presentation. And if you missed any of our previous sessions, please do feel free to listen to them, to the recordings. You can go on our websites, BSO and CLRI, and listen to the recordings. Thank you, everyone. Have a great day.
Thanks, everyone.